Welcome, Dr. Naveed, sir.
Good evening. Good evening,
Hello.
everyone.
Good evening.
Doctor,
Good evening.
I can see
Welcome, sir.
Thank you.
Welcome, sir. Naveen, sir, welcome.
Dr. Badresh,
Welcome, sir.
Yes,
Dr.
sir.
Gandhi,
Yes.
Dr.
Yeah.
Kirendra Sharma, Rakesh, Swati Bhatt, madam.
Yeah.
Thank you.
Welcome, sir.
Dr. Dilip.
Naveen, good evening.
How are you, sir?
Fine, fine. Thank you.
How's the health?
Much better.
That's great. That's good. That's good.
Good evening, sir. Good evening.
Good evening, Rakesh. How are you?
All well, sir.
So, yesterday we both were managing two things simultaneously, eh?
वहाँ पर तो ज़्यादा काम नहीं था सर कुछ क्योंकि जस्ट ऑब्जर्व करना था कि हाउ दे आर गोइंग अबाउट.
हाँ जी सर, डॉक्टर बद्रेश.
Yes, sir.
आज अभी लाइव तो नहीं है ना?
Yes, sir.
आज अनाउंस we are live?
Yes, sir.
Yes, sir. Yes, sir.
Okay. Then I'll keep quiet.
Yeah, Atul, 6:30 now. You can
Welcome करो ना.
Yeah.
make everyone online.
Atul.
Open the link now.
Hello. Okay. Can we start?
Yes. Yes.
Good evening, dear friends. I, Dr. Atul Gandhi and Dr. Preeti Patel, moderator of the today's webinar. I feel honored to conduct the webinar organized by Indian Society of Anaesthesia, Gujarat State Branch. First of all, I take opportunity to welcome our National Secretary, Dr. Naveen Malhotra, sir. Thank you very much, sir, for giving our precious time in your busy schedule. Dear friend, as you know very well that post-COVID anesthesia dilemma has become one of the matter of chief concern for our medical fraternity, one of the fraternity across the globe. It has also been our endeavor to bring together the scholarly researchers of our field and get benefit of their knowledge and experience. We have been holding a series of webinars. Today, indeed, I feel pride that we have eminent scholars such as Dr. Rakesh Garg, Dr. Gitendra Sharma, and Dr. Hemant Kanse, who are renowned for their expertise in their field. The webinar is specially supported by Alkem Pharma. Thank you very much for supporting us. This will be our practical webinar session, which will help all anesthesiologists across the globe in practice during this period. So, not making more much precious time, I request our President Swati Bhatt, sir, Madam, to give her presidential address and welcome our all delegate and Dr. Naveen Malhotra, sir. Please, Dr. Swati Ben.
Good evening, Malhotra sir, Dr. Rakesh Garg sir, Jitendra sir, and Dr. Hemant, office bearer of Gujarat State Branch, and all delegates. I welcome you all on behalf of Gujarat State Branch IESA. Thank you all speakers, Malhotra sir, for sharing your valuable time, and you are always there whenever we have a call for you. Before starting our academic session, I would like to pay homage and say a few words regarding Dr. Geetaben Patel, who have lost her life fighting the COVID pandemic. Dr. Geetaben Patel, she was a government employee since 15 years at Palanpur. She had many medical problems, even though she decided to fight and serve in the government hospital. But unfortunately, she lost her life. She was a brave-hearted and a very powerful soldier. May her soul rest in peace. Thank you all. Now, I request all speakers and all delegates to join the webinar. Since the COVID pandemic, we have many conflicts, dilemma, and confusion. So I hope and I wish that this webinar will give us the true path and will show us the solid solution to fight this COVID pandemic. I say I'm very grateful and thankful to Malhotra sir for always connecting with our Gujarat State Branch and sparing his valuable time. Dr. Rakesh Garg sir, who is a prominent academician, a speaker. Dr. Jitendra Sharma, basically he is an obstetrician. And Dr. Hemant, I welcome you all and hope this will be a very interactive academic session. Thank you all.
Now, We can start academic session. I invite Dr.
Atul, just a minute. First of all, give 2 minutes to our national secretary, sir. For his,
Malhotra, sir. Malhotra, sir,
yes, sir.
please.
Malhotra, sir. Yes.
Yeah.
Thank you to Gujarat State Branch for inviting me to the today's webinar. Yeah, I always cherish whenever you send an invitation to join. It's my pleasure.
Yes.
With folded hands, I pay homage to Dr. Geeta Bhavesh Patel, whom we lost recently from Palanpur, Gujarat. May her soul rest in peace and God give strength to the bereaved family. As far as Gujarat State Branch or GSB, as it is commonly known as,
Yes.
I am very happy with Madam Swati Ben Bhatt in the chair and Badresh Bhai Shah as secretary and Dr. Atul Gandhi as treasurer and with other senior members like Dr. Rashesh Diwan. All the programs of ISA National, they are immediately implemented at state level. If I talk of recent last 7-8 months, whether it is distribution of grant in aid for buying PPE kits, distribution of PPE appreciation certificates, ISA national certificates to the PPE-led COVID warriors, ISA online mechanical ventilation course, ISA sports club. This was the first time intra-state competition done by Dr. Badresh Shah and his team at Ahmedabad.
Thank you, sir.
And we had a vision of holding a national level event on second weekend of 9th and 10th January 2021. At that time, COVID was not there, but I'm very sure. And with the turn of events occurring in health sector, New Year will become new horizons. And that national level sports competition will be held in Ahmedabad only. Whenever it is physically fit to travel.
Yes.
Also, I'm very happy about the ISACON 2020, the way the things have been managed on rescheduling. And I request Dr. Rashesh Diwan and Dr. Sunil Shah to please continue with the quiz. It has generated a good enthusiasm. So I request you, as you have dealt with the request of the members of our registration and very aptly satisfied them, I request you to please restart the ISACON quiz also. So that generates good interest.
Yes, sir.
All the other programs of ISA, like ISA Cultural Club, Art and Literary Club, there is an active participation from Gujarat. Very active participation in ISA National Task Force on COVID, clinical coordinators also by Dr. Hina Chanchalwal and Dr. Devani Desai. In Cultural Club, so there are lots and lots of performances, Dr. Ketna Agarwal and many other members. And we have got in ISF, we have Vice President is from Gujarat, Dr. Asit Vaisnav from Rajkot. And if we talk of ISA stars, there have been so many ISA stars at the national level from Gujarat state. Lots of innovations, especially in airway by Dr. Apex Patwa and Dr. So many, I won't name them, so many other things. And whether it is private practitioners forum also, there is a very active participation. UISA, there is tremendous response from Gujarat and there were lots of participants and winners from Gujarat state. For social outreach program, there has been whether it is calls activity or whether it is World Environment Day activity, there is a tremendous response. And last but not the least, if we talk about ISA financial advisor, who are the best planners of finances, then our Gujarat colleagues. So Dr. Gajjar and his team is advising all of us how to do a good financial planning. And Gujarat State Branch is aptly supported. I must say your team is also good, whether it is Ahmedabad, Vadodara, Rajkot, Palanpur, Bhavnagar, Jamnagar, Valsad, Anand, Surendranagar, Surat, Navsari, Mehsana, Palanpur, all the 13 branches, they are all very active. And on this today's webinar is an auspicious day. So I announce that the Governing Council has approved the formation of your 14th branch of Sabarkantha and Aravali.
Yes,
So
thank you, sir.
now you have got 14 branches And
Right.
the credit goes to Dr. Swati Bhatt and Dr. Badresh and your team. But Dr. Badresh has to remember that he has to have those many city branches in Gujarat, in his tenure, as there are MP seats,
Yes, sir.
parliamentary seats. Okay.
Yes,
You have
sir.
got
Yes,
25,
sir.
25 parliamentary seats?
26.
26. So 26 branches you have to go. So you are at
Yes, sir.
14.
We will
So-
try our level best, sir.
Yes, sir.
madam. Yes, madam.
With
I'm
your
very sure.
blessings and-
I am always there with you.
Yes, sir.
Coming on to, and you have been holding academic programs also regularly and clinical programs also regularly. And today's webinar is in that series. And I was talking few days ago in the National Airway Conference, and Rakesh was one of the pro-con thing. And I told, we just had a discussion and told, so we are not talking about COVID patients or COVID negative patients or COVID positive patients. Now we have to start thinking about post-COVID patients also. And there is no dilemma. I can, I was just seeing about the dilemma. We have to be clearing the dilemma very, very clearly. And ISA is working on that. And this is the reality now. All these patients who have turned COVID positive and then subsequently negative, they will come for surgical procedures in near future. So we have to know what all has to be done in these patients, what all organs have been affected. You start from top to bottom. All organs are affected, and Rakesh will throw light on that. Whether it is brain, neurological things, whether it is eyes, whether it is teeth, whether it is smell, whether it is taste, whether it is ears, whether it is your reflexes or baroreceptor, whether it is the heart, whether it is the lung, and so many things happening in the things, whether it is hematological, whether it is the interstitial one, whether it is the kidneys, whether it is the gut, whether it is the muscles, each and every organ of body is affected, whether it is the endocrinal one, immunological one. So we anesthesiologists should now be prepared. Yes, I am very hopeful that this pandemic, we will soon overcome it. But we have to be prepared for dealing with these patients. And this topic is very pertinent in that aspect. And there are another issues of ethical dilemmas, which Dr. G. Sharma will be talking about it. And pain management role of paracetamol. Paracetamol is usually crocin, dard ki dawai, but yes, it is the very, very important and very, very useful drug. So I wish good luck to all the speakers and the panelists. And I am once again thankful to GSB for inviting me here. And it's always, I feel that I am not at in Haryana, but I always feel that it's one and the same thing. Thank you very much for your love and affection. Please keep on showering your blessings and love on me also and on ISA also. Thank you very much. Long live ISA. Jai Hind. Thank you.
Thank you, sir. Thank you, sir, for your
Thank you.
kind words.
Thank
Thank you, sir.
you.
Thank you, sir.
Thank you.
Thank you very much, sir. Now we can start our academic session. First, Dr. Rakesh Garg, sir. I invite Dr. Pritiben Patel. She is our president-elect of next year, Gujarat State Branch. I may welcome to President Dr. Pritiben to invite our Dr. Rakesh Garg, sir.
A very good evening to everyone present here. It is my great honor to be a part of such an august gathering. Dr. Naveen Malhotra, sir, your presence is a blessing, and we hope that we all are able to seek your guidance and imbibe something from your thoughts. Thank you, Dr. Atul, for giving me the honor and privilege to introduce the first key speaker of the today's webinar. What do I say about our eminent speaker? I fall short of words and try to give a brief to his credit. This of Anaesthesia and palliative medicine at All Science, New Delhi. Our distinguished speaker has more than 250 national and international publications in his name and has authored 20 chapters in various books. He is an associate editor in India's most leading journals of anesthesia and editorial board member in 12 national and international journals. He has conducted over 50 various workshops and has delivered more than 120 case lectures at various conferences and workshops. And last but not the least, he has received over 12 national and international awards in his name. COVID-19 outbreak has posed many challenges for the anesthesia community. Guidelines are changing very fast, and one of the biggest problems that our fraternity faces today is getting hold of the accurate information that can help us ease the anxiety about the patient management. To clear our doubts in clinical practice, I am pleased to welcome one of the most renowned and multidimensional personality, Dr. Rakesh Garg, for his presentation on post-COVID anesthesiologist's dilemma, whose wide-ranging expertise on this subject will clear our doubts and shed light on the issues involved in clinical practice. Please join me in welcoming Dr. Rakesh Garg. Dr. Rakesh Garg, sir, please.
Thank you so much, ma'am. Thank you so much for the kind introduction. And my special thanks to Dr. Swati Bhatt, Dr. Badresh Shah, the ISA Gujarat State Branch dignitaries for the kind invite. Thanks also to the senior members of ISA Gujarat State Branch, Dr. Atul Gandhi, who has been interacting for this seminar for the day, Dr. Ashish Diwan, Dr. Amish Shah, Dr. Apex Patwa. My sincere regards and thanks to all of you to give me this kind opportunity to interact with you at the webinar for the ISA Gujarat State Branch. And my special regards to Professor Naveen Malhotra for kind introduction, and to see always a smiling face and enthusiastic face always on various academic platform. Thank you so much to you as well. So when we talk about the COVID, I think we have been discussing about COVID for the last couple of months, probably when the first case reported, and then we have been seeing various dilemmas, various controversies, various concepts which are emerging. But now I think when we are saying that it's a time to accept and adapt to the new normal, because COVID is emerging. Probably it will remain us for some more months, probably till we get some vaccine or it starts getting community immunity starts developing. Till then we have this COVID, so we have to adapt it, and we have many patients who have recovered for it. So we have to think of that how, because the medical services will not be stopped, they will continue. So what strategies we need to follow that, so that not only the patient remains safe, but also the whole anesthesiologist fraternity also remains safe when they are serving the community from various aspects, whether it's a COVID area or a non-COVID area. I bring greetings from my institute. I work at the Cancer Center of All India Institute of Medical Sciences, which has out campus also, which is now working as a COVID center and one of the bigger center available here. Now, this small, tiny virus, we do not know that it will create havoc globally. A small virus, which was a novel virus, but it had changed so many aspects. If you think it just medically, no, it has impact on financial aspect, psychological aspect. It has just changed the Pandora of each and everything, not only in specific centers, as we have seen in the previous pandemics, they were focused one, but this COVID-19 has been quite notorious that it has not left any place in the world. And with the management strategies that we are having, it has created dilemmas. And dilemmas are primarily because it is a novel virus. We do not know actually how it's going to behave in a short term and long term. We were just experimenting, data were coming from different places, and then we were progressing further and further on. So there were many dilemmas, and dilemmas like how and when to assess the COVID status in the beginning, or once the patient is treated, or when the patient is posted for surgical interventions after the COVID positive status. When does the body physiology returns to normal? Because in anesthesiology, we are always talking of a normal physiology before the planned operating procedure. So when we take a patient is hypertensive, when a patient is having an interstitial lung disease, we always think that probably this much, 4 weeks, 6 weeks, 12 weeks will be a period, a window period where possibly after the insert of the body, with any infection or other disease, the patient physiology will start coming normal, and then we can take up an elective case. So when can these be operated? What extra from routine PAC? We are doing a pre-anesthetic checkup for these patients, but will COVID-19 will change the aspect of PAC, not only in the format, but what extra things needs to be assessed? Because we know if a patient is a known case of hypertension, we have to look for the end organ damage. If a patient is a diabetic, we have to look for the end organ damage. If a patient is a CAD, we have certain things to look for. Now, when we say when a patient has a history of COVID-19 positive, what need to look for? That also becomes essential, I think, and that will modify our pre-anesthetic checkup subsequently in coming days when these patients are posted for various electives and emergency surgery. And that will be primarily because of the long-term impact on the body system that needs to be looked for. So what to do, what not to do is basically a dilemma in this scenario, and we'll try to solve out some of these aspects. But let me tell you, my take on this will be, I think I will be able to reply some of them. Some of them needs to be extrapolated from possible previous SARS and MERS, which has emerged years back, and based on this, some extrapolation can be done for these, and some still remains unanswered, which will come with time. So let's come to the first state, when and how to assess the COVID status. I think this is one of the recent ICMR has brought out the update for the testing procedure. Now, this is, I think, very clear. This is not going to change now. This has been well proven. When we say testing for COVID-19, whether we are talking of the primary diagnosis or we are talking of a patient who is scheduled for surgical interventions, maybe urgent surgery or elective surgery, the choice of tests are very clear. To begin with, we started with RT-PCR, which takes a little longer time. But then we realized that the TrueNet and CBNet, which are initially were used for tuberculosis analysis, tuberculosis diagnosis, they were also found to pick up these tests, and they are a little faster. RT-PCR probably because it is an multi-kit, it takes about 6 to 8 hours, 10 hours. TrueNet, CBNet are cartridge-based. They can be done within 1 to 2 hours, so they're a little faster. So these remains first line of choice of test whenever any patient is being tested for COVID-19, whether primary or a patient posted for surgical interventions, any type, major surgery or minor surgery, this can be the one test that can be done. If these are not available, or there is some urgency where you want a very fast test, a rapid antigen test, which is a kit-based test, as we do for troponin I or maybe urine pregnancy test. These are the similar kits wherein the sample can be taken, extracted, and put, and it will give you a result faster as compared to the RT-PCR or TrueNet or CBNet. So this can also be done, but yes, the sensitivity and specificity of this test is a little lower than the RT-PCR test. Now, when these tests needs to be repeated, that's again a major issue now. Now, to begin with, everybody of remember that if in the beginning, if somebody becomes COVID positive, they were repeated with 2 tests at 14 days, 24 hours apart, and then you used to say it was negative. Now, this is a big issue, because then there were a couple of patients which were coming up which say they were repeated positive, and there were a lot of queries that a patient was coming RT-PCR positive on 14th day, on 20th day, on 30th day. They were constantly coming positive, and a lot of queries and things and so forth. Literature was coming out. So a single RT-PCR TrueNet or a CBNet or a RT test positive is to be considered confirmatory. So there is no repeat testing, because they if positive means positive. Only concern will be when they are negative, because the sensitivity is somewhere around 70%. So we may miss some of the test. So if negative, then we should be cautious based on the symptomatology, based on the contact, we can repeat those tests. But if they are positive, we have to accept them. So no reset testing is recommended prior to discharge from a COVID-19 facility after a clinical recovery, including from transfer to various. Now, this is important. The reason is why these tests were coming, especially the antigen-based test, why they were coming positive on 14th day, 20th day. They were a little longer positive for immunocompromised patient, because all of us know that steroid has become one of the component of the therapy for COVID-19, especially the moderate and severe category. And when the steroid is given, the viral clearance becomes slower, and that's why they may be having positive test for a longer duration. But positive test does not mean infectivity. Now, this point needs to be very clear. So when the virus is being taken care by the body, it is being killed by the body immunity, the dead antigen will circulate in the body for some time. The degraded virus of COVID-19, coronavirus, will continue in the body. So now this test, RT-PCR or cartridge-based test, picks up those antigens. They will not pick up the infective antigen only. They can pick any degraded virus. And that is why the test will come positive for a longer duration. So that's why it was realized that most of the time by 9th or 10th day, the infectivity of the virus goes down. The dead virus from the body, the clearance takes a little longer time depending upon body response. If a body is immunocompromised, it may take longer. And that's why it was said that there is no need to repeat the test in otherwise normal patient once they have treatment for 10 days or so. But if the symptoms develop following a negative rapid antigen test, a repeat RT or RT-PCR should be done, because I said key rapid antigen test is having a lower sensitivity, so you may repeat it in case if the patient is symptomatic. Now this is how the rapid antigen test is. So I said any test which comes positive, it has to be positive. So there is no confusion about it. So it has to be accepted positive. But if it is negative and patient is symptomatic, which is with the conventional symptoms like fever, cough throat, sore throat, myalgias, headache, then we need to repeat it by sending more confirmatory test, which is RT-PCR. If the patient is asymptomatic, then you can wait, hold it on, and then if the patient becomes symptomatic, then only you need to get it done. So this is how we need to look for the various tests which are available. So I have talked about the RT-PCR, I have talked about CBNet and TrueNet, and I've talked about the kit-based test, rapid antigen test, how they can be integrated into a primary diagnosis or a diagnosis prior to any of the operative procedure, or maybe the admission into any of the hospital-based area where they need some type of medical management. But remember, if it's an emergency procedure, we cannot wait for them. But it is very clear that I will be repeating this sentence many times throughout my slides, that an appropriate personal protective equipment should be geared up wherever you have any suspicion, at least till the pandemic goes away. So the sample needs to be sent. We may not be waiting for the report, but yes, we have to send the sample, but the emergency procedures must not be delayed. So whatever the emergency procedures are. Now, just I want to differentiate here. You can go around and look for the CBNet or TrueNet, which gives you an earlier results as compared to RT-PCR, so you can get a faster results and can take a decision accordingly. So continuing with this, if you see the whole arena of the virus, that how it goes around, and that will help you for various surgical intervention. So when anybody is exposed to the coronavirus for whatever reasons, there will be an incubation period, which may be for various reasons of 3 to 5 days, and then probably the symptoms will start. So this incubation period is an area wherein you may not have a positive result. Patient is a virus carrier and can contaminate various surfaces. This is a big issue where we should be cautious for the incubation period. And then there are onset of symptoms where obviously we have a high index of suspicion, they can test positive. So this initial incubation period, patient may not have symptoms, one, patient may not be positive, and that's why the test is being done usually at 5 or 7 days, between 5 to 7 days, when the chances of positivity is much higher. So this incubation period, at times when a patient is posted for surgical intervention, this will be an area where our healthcare workers can be infected. So we have to be cautious, and that's why I'm saying that till the prevalence or the community appearance of COVID-19 is there, we have to be cautious for COVID-19, and we should assume that these patients should be COVID-19, and depending accordingly, we can take the precautions for various type of PPE. And then subsequently, patient will have pulmonary phase or hyperinflammatory phase, and depend upon further whether patient may recover or patient can have subsequent morbidity or mortality. Now, this is what we also say, that nowadays we have antibody testing also. There is a combined antibody testing which measures both IgM and IgG, or there could be individual one. But remember here, I mentioned that I think this is important when we are managing these patients, that the initial window period which will be missed because patient will not manifest symptoms, the test may not come positive. That's why we have to be extra cautious. We cannot keep a patient into quarantine for a week before we say that he is fit for surgical procedures, because the admission may not be a good norm here. So that's why we should be cautious procedures during this window period, and then patient can have starting symptom positivity. The other factors that can help you for infectivity will be that the IgM starts coming up. So when the IgM is coming up, this means the patient is mounting the acute response, acute immunological response. So this is a phase where patient will be having more of an infectivity because IgG has not developed, IgM has not disappeared. So again, this 7 to 14 days when it peaks, the IgM peaks, it is a period where the infectivity will be much higher. So we should be cautious when these patients are managed in the operation theater, that if they are going positive, then probably we need to wait for until it's an emergency surgery. But once the IgG starts mounting, IgM disappears, then we can say the patient is non-infective, patient has acquired immunity because of the infection, and probably we can go ahead and do the surgical intervention. So this understanding of the time frame becomes very, very essential. We say that the IgM starts mounting on by 7 to 8 days. It peaks by around 2 weeks or so, and then by around 3 to 4 weeks, it starts settle down. By around 2 to 3 weeks, the IgG starts on, and then it peaks by around 4 weeks approximately or so, where it is having a peak level, and then probably plateaus. And we do not know that how it will tapers off. People say that the chances of reinfection could be there because IgG is not prolonged for a longer duration, and that's why immunity is not for a very prolonged period. That also needs to be looked for. Now, when we say the preoperative testing, I think there are a couple of articles which has been published globally, and they mentioned that there is no confusion as of now that we need to have mandatory preoperative testing. Now, this is, I think, will be a plan as of now and in future also. So we are predicting that probably in next around, say, 6 months or so, if we talk of the India, when we are expecting that there may be a little surge in coming this winter season, somewhere around November, December, there may be a little peak, and then will settle down. But finally, the herd immunity or the immunity in the community will take some time. So this will be two situations I am talking here. So now there will be one situation where there is a local or regional presence of the coronavirus in the community, because all of you know that we are working in this place. We are aware that our target population who are coming to the hospital is coming from zone where still the COVID virus is happening. And subsequently, maybe say 3 or 6 months down the line, when we see that the community, the herd immunity has been acquired in that particular area from where the patient is coming up. So there will be little or no regional presence of COVID. A patient will be settled down. So maybe the second column, which I'm mentioning here, probably will be coming somewhere in March, February or March, which we are expecting. So in that situation, the planning may be as per the second column. So till where we have the appearance of SARS-CoV-2, the screening for symptoms needs to be done whenever these are patients planned for any surgical procedure. So I think we have discussed in the previous platform also. Now this screening needs to be done with various modality depending upon the infrastructure available. But I think a telecommunication mode that what we are doing at AIIMS is one of the good option when a patient is posted for any surgical, he's giving him date. So maybe a week prior, a telephone call goes to it. We have a prescribed checklist which says about the contact history and about the symptoms. If patient has symptoms, we always say, okay, your surgery needs to be postponed if it's not urgent surgery or emergent surgery. And this telecommunication mode will prevent the exposure of these patients to the healthcare worker, and we can take a balanced view. In case if they have symptoms, you need to refer them to the COVID centers, and they can get them testing done. But in case if a patient is coming from an area which will be coming, say, maybe in subsequent 3 to 6 months, where there is little or no regional presence of evidence of COVID-19, still we need to look for the symptoms. And if the symptoms are there, then we need to refer to the additional evaluation. But routine testing may not be required once this stage is reached, but we have to wait it for some time. But on the other side, as of now, we have to done an RT-PCR testing for all the patients who are coming for surgery. So this second phase, second column, which I'm proposing here, will be when the community immunity will be achieved, and then you can stop doing regular conventional RT-PCR technique. But always remember, whatever the situation is now, or maybe in the second column, which I mentioned subsequently, we still have to take appropriate personal protective equipments when we are managing, especially with the aerosol generating procedures. So assess all the symptoms as per symptomatology for COVID-19. And this is very, very concerned because many of the patients are asymptomatic. But the most common symptoms that patients are manifesting are related to the respiratory symptoms. But in addition to respiratory system, I think gradually when we started in December, January, it was respiratory system. But I don't think now any system has been left by COVID-19. This virus is notorious, and it is involving neurologic disease, starting from anosmia, starting from headache, dizziness, encephalopathy, brain edema. It's causing everything. Even for renal, it is causing acute renal injuries, maybe because of direct inflammatory response, or also because of the various microthrombosis that are going into the renal system and blocking them. Even the hepatobiliary system is being affected by the increase in the enzymes. The GI system, many of the patients have presented isolatedly with diarrhea only as a COVID manifestation without any disease. Thromboembolism, it is one of the major phenomena which is hampering, and it is leading to a very large spectrum in the form of stroke, neurological symptoms, MI from the cardiovascular system, from the DVTs, from the ventilation perfusion mismatch because of thrombosis of the various cellular perfusion. So this thromboembolic phenomena is again a big issue. Even cardiac, it's just not the MI. These patients are coming with various amount of the cardiac muscular edemas and myocarditis type phenomena with arrhythmias. So these needs to be looked for at how they will behave in the long-term follow-up, either with fibrosis or they will return back to normal. The endocrine, the patient is showing hyperglycemia. Many of the patients who are having some controlled diabetes mellitus are presenting with diabetic ketoacidosis when they get COVID-19. So it becomes a major issue. And obviously, there are many dermatological manifestations. We have seen patients who were in the initial phase who were just having some rash or erythemas on the body with no other symptoms. So this means these are the symptoms that needs to be looked for, and we need to follow them up. I'll just take you in the subsequent slides that how these needs to be followed up in the future also, because we do not know exactly that what residual harm they will leave on the various system once they have been taken care of. So coming to this, I'll just divide my subsequent couple of slides into whether they are COVID-19 positive and recovered, and now they are posted for surgical procedures, which probably now these patients have started coming up who has got COVID status in past 2, 3, 4 months, and then they require surgeries. And see, these number of cases are going to increase it. So if some COVID-19 positive patients who has been treated and now he's posted for any type of surgical procedures, so we need to remember that the elective surgical procedures should be delayed until the patient is no longer infectious. No longer infectious, I mentioned that it is around 10 to 14 days that needs to be taken care of, but they need to demonstrate a recovery from COVID-19. So how can we confirm that these patients are non-infectious? So they can be based on test-based strategies or non-test-based strategies. So in the beginning, maybe in February, March, April, we were more of a concern with test-based strategies, where with the resolution of symptoms along with negative results using RT-PCR was considered as patients to be non-infectious. But subsequently, now the non-test based strategy is more commonly acceptable because there is sufficient data to say that the infectivity goes down by around 9th or 10th day or so. So now we are following the non-test based strategies once a patient is COVID-19 positive. So we say that patient has at least 72 hours the resolution of fever without the use of any medications like anti-inflammatory or antipyretics, and the symptomatology which was on the baseline has improved, or the patient has at least 7 days since symptoms first appeared. So it will be approximately, I said incubation period or window period is somewhere around 3 to 5 days. So it will be around 10 to 14 days. That will be based on this. We can say that patient is non-infectious. Now this strategy may be considered in patients who are immunocompetent. So if a patient is posted for surgeries, you can wait for 2 weeks so that he becomes non-infective, and then subsequently usually we say that because the patient has a lot of inflammatory response, patient physiology has deranged, we can wait for another 2 weeks so that they can optimize. But then the infectivity versus normalization of body physiology, there are two phenomena that can be considered. So what we need to do is all procedures, the patient should be screened for exposure and symptoms, which I just mentioned. If a patient is previously COVID positive, if patient is diagnosed within last 14 days, treat them as positive. No testing is required, but yes, there could be a chance. Now it's an emergency surgeries, take all PP precautions, level 3 precautions. If patient is not an emergency surgeries, patient can wait for another 2 weeks. You can wait for another 2 weeks, and then after 4 weeks, we can get the surgery done. If patient was diagnosed within last 15 to 20 days, obtain a repeat test to be treated as negative, otherwise treat as positive, because there could be some concerns in a patient who are immunocompromised, who has received some steroid therapy. So this is that's why we say that a window period or a period of 4 weeks may be deferred for patients who are posted for elective routine surgeries, which are non-surgeries. All other outpatients, our testing should be required within 2 days prior to the procedures. So that is very, very essential. So I think this is how in future we need to decide that when to test, whom to test, and how much needs to be repeated. Now, this again needs to be remembered here. Now, we are seeing a couple of cases, though they are not proven, that the reinfection is happening, and they have been being reported from India. This is one aspect. The second worrisome aspect is that some of them who has been infected, and when they are getting their antibody titers done, the antibody titers are not coming to a normal protective level. So this means the antibody response in the body may not last long. So we cannot be very sure that if somebody has suffered from COVID-19, he will have a immunity with the antibodies for a longer duration. So we do not know. So this means that the duration by the immunity developed with the infection, the duration is unknown. And that's why I said use PPE more cautiously. The reinfections can still happen. A couple of cases are there which has confirmed out to be positive. Though we do not have a robust data, they are unproven. But this just makes us a little cautious that in case if a patient, even though has a past history of COVID-19 positive, but shows symptoms which are suggestive of COVID-19, they should be taken as COVID positive, and all precautions needs to be followed by the total perioperative care team. Now, this is how we can categorize. I think this will be a useful slide for each one of us. Now, in case when you test them prior to the surgical procedure, if the patient is COVID negative, what I mean is not in the form of RT-PCR negative, that is COVID test negative, antigen based, but they should be clinically asymptomatic. If yes, then go ahead and do the surgery. So this will be applicable for probably next 3 to 6 months. Now, in case if a patient is COVID suspect, by COVID suspect, I mean that the COVID test has not been done, or sample has been done, but the reports have not reached us, but patient is clinically suspicious. In that situation, again, if you think it's an elective surgery, you defer, repeat the test, wait for some time, and then take a decision. But in case it's an emergency surgery, assume that patient to be COVID positive, even though the initial test was negative, because sensitivity, I said, is around 70%, so we miss it. So the whole perioperative care team should take all precautions. If patient is COVID positive on any of the tests which we have described earlier, the routine surgeries needs to be deferred for 4 weeks. The patient may be shifted to the COVID center or a home quarantine depending upon the symptoms. And then after 4 weeks, we can take a decision. But if patient is emergency, obviously, all emergency surgical procedures needs to be followed. They should not be delayed. And the total perioperative team should follow the norms of COVID positive. Now, subsequently, when this dilemma or transition will be happening where the immunity in the community is increasing, we have to think of these two important aspects, the technical aspects and the adaptive aspects, because now when we do a routine PACs, we need to change our routine PACs. So we have to incorporate the SARS assessment and testing into the perioperative workflow of our pre-anesthetic checkup. For technical aspect, we should have a system as we test for hemogram or X-ray or ECG. We need to have a technical aspect wherein patient will get a testing protocol so that it becomes streamlined. Second is the adaptive. Now, for example, say when we get the viral markers done in a high-risk patient or something like this, we need to have an effective communication with the patients and the team so that they understand that they have to adapt to the system. And this is an additional test which is required for the perioperative management. So this integration needs to be there into our PAC checkup now, and the incorporation of telemedicine would be a great help. So this is what I summarize in the what you have said in the last couple of slides. So in case a patient is planned for surgical procedures, you need to assess the patient for symptomatology a week prior and look for whether the patient needs to be rescheduled or can be posted for surgeries, or whether patient is urgent, emergent versus routine surgery. So once this has been done, maybe around 2 days prior, patient needs to have COVID-19 testing done, which will be usually based on some antigen-based test, and then he patient needs to be admitted and the surgery can be done. So this should be the flow. And definitely I will suggest here that the incorporation of telemedicine as per the NMC guidelines may be incorporated, so that patient has not to visit the hospitals multiple times to get all those parameters done, and has a little chance of interacting with patients who are positive. And we will be able to maintain those social distancing criteria. So I think telemedicine will be a huge help in the coming days, and everybody needs to incorporate according to their institutional protocol, that how in hospital, out of hospital, we can expand the access to the healthcare services, especially related to the preoperative checkups, so that the visit of the patient to the hospital is minimized and the patient remains safe at home. Now, this is what we have just talked about, including these things. So when a patient is talked about when patient is being treated for this type of procedures, we should be cautious. Am I audible?
Yes, sir. You are audible, sir.
All good, Rakesh.
Yes,
All good.
sir.
Carry on.
Right. Thank you.
Yes, sir.
So just to summarize once more, so what we said, in a patient who is COVID-19 posted for any surgical procedures, then in those situations, we need to test them, assess them a week prior, and accordingly, you can just term the COVID survey, and based on this, you can take a decision. If a patient on secondary survey, second symptom survey and COVID testing done, if a patient is positive testing, then postpone the procedure. If it's negative, proceed to the surgeries. So this is how you can just take a decision. This will be applicable for not only for the present pandemic, but when the weaning phase of the pandemic will start, again, this will be acceptable in those situations also. Now, so this is an important statement we need to emphasize for the elective surgeries, that the recommendations regarding the definition of sufficient recovery from the physiological changes from SARS-CoV-2 cannot be made at this time. Now, we are looking, because it's a novel virus, so how much it will have impact on different body systems in a long-term phase, on a follow-up phase, there needs to be coming with time. Though we have a little bit of small data, but then we need to subsequently wait for. But now the important point here is that at this point, in a subsequent coming months, we have to look for the additional evaluation in context to the patient's COVID-19 status and its effects on the body systems, specifically the respiratory system, which is always of a concern to us. So those who are recovered from COVID-19 remain vulnerable to long-term effects with increased morbidity and heightened mortality risk, which has been in a small population outcome has been seen in various populations. Also, we have to look for the side effects of the various drugs that has been used. So to start with, we were using a lot of drugs like IL-6 inhibitors, various antiviral drugs, including remdesivir. But many of the time, these drugs are coming to be negative. And recently, yesterday only, a press release by ICMR say that even remdesivir has not found to be much beneficial. The convalescent plasma has not been found beneficial. But steroids has still be continued. Ivermectin has some role. So this means we need to look for the effects of these drugs, as at a couple of places, drugs like steroids are being used for longer duration, and what impact will they have, that needs to be looked for. So as COVID-19 pathways and patterns of COVID are being developed by hours a day, our existing systems are vulnerable, and because frontline providers are unfamiliar with new guidelines, leading to confusion and miscommunication, that's the reason that we need to update. We need to be getting a knowledge that what happened in March, what happened in April, and what we are looking for. If so, we have a brief idea, it will be easy for us to have a clinical follow-up. COVID-19 proven to have many extrapulmonary effects. As I mentioned earlier, it causes a widespread tissue hypoxia, primarily because of the inflammatory response and microthrombosis. There are multiple systems involved into different degrees. And for long-term follow-up, we have to look for various data we do not know. But just to summarize, in the PAC setup, when these patients will be coming to us, we have to look for the impact on these systems at the baseline level when the patient was infected and how they have recovered over time. So for example, a patient who was infected, say 3 months back, And he says that he was having some neurological symptoms, like he was having some lightheadedness, dizziness, patient was having anosmia. So this means there was neurological insult at that point of time. So we need to follow them up, that how they have recovered up. Similarly, pulmonary. So pulmonary response, probably it appears that it will be followed with pulmonary fibrosis, as happens in similar ARDS phenomena or previous insert by the SARS and MERS episodes, which has happened a couple of years back. So this needs to be followed up, that what pulmonary residual symptoms or residual insult has occurred because of the COVID-19 infection. Similarly, GI and hepatobiliary patient can have long-term anorexia and nausea if they are posted for major surgical procedures. Then we need to look for that whether they have hypoalbuminemia, because hypoalbuminemia is an independent predictor of increased morbidity and mortality. So we need to look for a patient may have, because of microthrombosis, there could be increase in the enzymes levels or maybe some amount of subclinical liver dysfunction. So we should have high index of suspicion. If a patient says that at the time of admission, he had increased liver enzymes 3 times, 4 times, 5 times of level, he has increased urea creatinine, or he has increased levels of various thrombotic parameters at the time of admission. So whether they have recovered to normal needs to be assessed. Similarly, the ENT eye, as I mentioned earlier, also CVS, this patient can have myocarditis and all those phenomena. The peripheral nervous system, again, important, because many of these patients would be admitted in ICUs for a prolonged period. So once the patient is going into ICU, especially those who are on ventilatory support or maybe on high flow oxygen, they are in the ICU for a longer duration, 2 to 3 weeks. So they can have various critical illness related morbidities like critical illness neuropathy, critical illness myopathy, nephropathy. So these could be the issues in the various system, especially with those patients who are admitted in ICU during the COVID-19. So any patient who had COVID-19 in the past, look for these symptoms, assess what the baseline symptoms were, how much time they have taken to recover, what were the drug therapies, and not what is the residual impact. So these needs to be assessed for these patients who are coming to us, and that will create a lot of concerns for us to assess them into a little different. So usually when a PSC say no history of diabetes, no history of hypertension, no history of other congenital disease or something like this, now we have to mention no history of COVID-19 status positive. So, and then if it's positive, then we have to look for various system evaluation so that we can capture some subclinical insult to the various systems. So a thorough assessment is mandatory when these patients will come up in future for any type of surgical procedures. Also, you need to remember that these are the patients in which probably the disease severity may be a little higher, especially the comorbid patients or the older age patients or some having genetic issues, so or immunocompromised status. So in these situations also, if these patients who had COVID-19 were in this age group, probably the insult to various organs will be a little higher. Same for the respiratory concerns. It has been proven, it has been shown that the long-term respiratory complications of COVID-19 are there. There will be a similar phenomena based on the extrapolation of the respiratory insult in SARS and MERS, which happened a couple of years back. Majority of symptomatic infections affect the respiratory system, we all know. The primary pathology is damage to alveoli and pulmonary capillaries, and which obviously affects the ventilatory exchange phenomena at the alveolo-capillary membrane. And now this can lead to chronic cough, fibrotic lung disease, bronchiectasis, pulmonary vascular disease leading to pulmonary hypertension. So these all phenomena can come up in future, and we have to look for that whether patient is manifesting them or not. Maybe that patient has recovered up. The recovery period we do not know, but it has been said that yes, they will start recovering after 4 to 6 weeks, but how much time they will take to recover normal, or whether they will become normal to the baseline, we do not know. And that's why the assessment of this becomes very, very important. The evidence for these possible sequelae is largely derived from the acute manifestations of earlier disease, and along with the extrapolation of SARS and MERS, which has happened 1.5 decades back. This is what the British Thoracic Society has come up, that probably a chest radiograph will be a screening tool We usually get a chest X-ray done in India for PSC checkup as a part to rule out tuberculosis and similar symptoms. But probably it will be now we have to look for any respiratory change, lung changes with the use of chest radiography. And a study is already ongoing, and we are looking for its result, wherein they will be recruiting 10,000 patients, and they will be repeating them clinical findings and along with a CT scan, and then they will come to know that how frequently or how the symptoms or the changes in the respiratory system improves, deteriorates, or maintains with time. So that needs to be looked up. So this means we have to apply a pragmatic approach for the patients who are coming for the surgical procedures. And then when you look for the chest radiography or oxygen saturation or pulse oximeter will become, I think, a normal tool in a PSC clinic for these patients, and we need to look for. We need to have an integrated system now so that patients will require a more integrative assessment tools from a multidisciplinary approach if they had some system insert during the COVID-19, and that needs to be looked for in the respiratory system. The thromboembolic events are well known in COVID-19, so they will manifest in various formats in the coming years because of the arterial thromboembolism, venous thromboembolism affecting the kidneys, the brain, the heart in various formats, and that needs to be looked for when we are talking of. So this means these patients can have subclinical insult to these organs because of the hypercoagulability and thrombosis because of the COVID-19, and the duration of increased risk of clotting we do not know. We don't have a data that how much time they will have, they will take to recover from this status. So this means whenever these patients are posted for surgical procedure, we should be extra cautious that they do not manifest increased insult in the form of thrombosis and embolism. We have to start them on prophylactic therapies. We can give them mechanical or pharmacological, so that needs to be taken care of. Coming to the cardiovascular concerns, these are again important because the complication, as we have seen in COVID-19, is related to acute MI, myocarditis, heart failures, cardiomyopathies, arrhythmia, shock, and even the cardiac arrest, as well as strokes and other thromboembolic events. Now, once this patient manifests during the acute phase of COVID-19, any of these symptoms, we need to follow them up at how much they have recovered from them. So the chances of impairment and long-term impairment needs to be looked for at which of these will come back to baseline or which of them will heal by fibrosis, and then there will be some residual symptoms. Similarly, the kidney injuries are insult happens because of many reasons. It will be the inflammatory response that happens. It also happens because of hypercoagulation. And with the ease of the lockdown now, patients who are high risk like diabetes, hypertension is also getting this infection. The chances of kidney injury may be a little higher. So we need to look for that how they will improve with time. Long-term effect of acute kidney injury because of COVID-19 needs to come up. But yes, again, we need to evaluate them with the microalbuminuria levels in the urines. If they have insult at the time of diagnosis, that needs to be looked for. Many of the patients who are responding is having anosmia, headache, severe fatigue. Some of them are also having other symptoms like viral meningitis and encephalitis. So these are the things that some of the residual symptoms will be left on. Not only this, but the peripheral neural system is also being affected. So when we are looking for the regional approach for these patients, we have to assess, for example, as we do for patients who are having past history of Guillain-Barré, past history of polio. Now, similarly, we have to look for past history of COVID-19 with neurological insult, and then we have to document it so that we can think of that what type of regional blocks will be safe for these patients, whether patient has some residual neurological damage or not. So that needs to be looked for. So this needs to be followed up. And not only this, but there will be a lot of neuropsychiatric symptoms that will come with time. So these type of neuropsychiatric symptoms are emerging in patients who have been treated with COVID-19. And this will add on the phenomena of delirium in the perioperative period, amnesia, and all those phenomena will club up in the postoperative period, especially the elderly population. And that obviously can increase the morbidity of these patients. So that's why we have to look for whether a patient has at baseline some of these neurological insults and whether they have recovered or not. Now, this is another very important phenomena which was seen in other critical illness, and people have seen in the COVID-19 in the acute phase also. And these are called chronic critical illness and the persistent critical illness. Now, these phenomena are very important because this type of illness is important for the patient's management, especially for major surgeries. So these patients may have poor nutrition, endocrinopathies, and all those phenomena. So you need to assess these phenomena so that the
Just 5 minutes, sir.
right
Lecture.
done.
Sorry for
Perfect.
that.
No issues. So that's why you have to look for these phenomena so that you can manage them nicely. Once the patient is posted for surgery, we are talking of the prehabilitative strategies. Now, we have to look for the prehabilitative strategies with regards to the now COVID-19 also, because we know that respiratory status is affected, patients' neurological deficit is there. So we have to look for such phenomena that can be incorporated. So still to go on, we have some times to go on. So we have to keep all preventive strategies, PPE kit, prevention measures, though we do not know the aerosol contained box are important or not, but PP remains important. Integration of telehealth remains more important. And then according to, I'll just summarize in very brief that the patient-related movement also needs to be restricted. When we say the patient is moving from ward to OR, we can minimize the patients moving from one place to other so that they remain stable. Prepare your areas nice. Your airway management technique should be safe. Only yesterday we have a new article which says that the extubation is more aerosol generating as compared to intubation, and they can be minimized if you follow your technique fast. You can do it, and they can be helping you to prevent the aerosol generation. It can happen, so you can choose your technique appropriately. Preparation, which we have learned in COVID-19, should continue for some more time till the herd immunity is there. Follow the guidelines. Have the equipments available with you which are more safer. Video laryngoscope probably will emerge from this. And this is the important slide where you say that you have to be ready. And with whatever the positive aspects have come up from COVID-19, that you are prepared, your resources are there, that staff has been retrained, that needs to be continued. So this is this whole phenomena which we have learned during the COVID-19 shall continue for some time, and the positive aspects of these needs to be continued subsequently. We should be keeping our area clean. Now, this was an issue in the previous aspect. The chances of infections were more in the critical areas, but now we have learned it, so we need to continue subsequently. We can have communication languages because speaking louder, they cause more aerosol formation. We can use these language charges. So just to summarize that in COVID-19, we need to remember something, that it's a novel disease. We know little about it. We are getting to know a lot more in coming days. So we need to keep ourselves updated. We are becoming more evidence-based and rational in coming time. We have to apply pragmatic and prioritize our approach. And that's the most important thing. Based on the available resources, training, we need to continue ourselves. We learn to learn, review, and adopt the new things. And keep the positive things going on. That's important. And we need to keep ourselves updated. So this is, I think, the crux of the future dilemmas. We can resolve those dilemmas by following all those things. And though it's new normal, earlier we can move around and see our patients. But now if you see in this diagram, it's a new normal, but still we can adapt it, accept it, and follow the normal techniques so that the patient remains safe. And also, the anesthesiologist community remains the same so that they can serve the community much better, much safer, and we remains healthy, then we can help our community much better. And all sincere regards, and I pay my sincere thanks to all the anesthesiologist community who are doing a great work in COVID-19, and they have a long way to go, and they will be helping the community in a much better way. Thank you once again, and thank you so much.
Thank you, sir. Nicely elaborated and very well deep. And now, running out of time, we are now going to the second topic. I invite Dr. Mangal. He is the secretary of Rajkot City branch, Gujarat State branch, to introduce our second lecture, and Dr. Gitendra Sharma. Over to Mangal.
Ethical dilemma in anesthesia. That is the topic for the next lecture to be delivered by Dr. Gitendra Sharma. Dr. Gitendra Sharma is practicing gynecologist and obstetrician in Ahmedabad since last 28 years. He is also a medical legal counselor. He has done his LLB with 15 gold medals and top Gujarat University. He has authored books on law on obstetrics and gynecology practice, consents in obstetric and gynecology, laws a doctor must know, These are the books he has authored and given more than 1,500 lectures all over India. Over to Dr. Gitendra Sharma.
Good evening, friends. Am I audible?
Yes, sir.
So,
Yes, sir.
good evening, friends. At the outset, I would like to thank Gujarat State Branch of Indian Society of Anesthesiologists, in specific Dr. Atul Bhai, for giving me this opportunity to interact with all of you. I would like to thank Dr. Swati Ben, Dr. Preeti Ben, Bhadresh Bhai for giving me this opportunity to interact with all of you. Today we are going to discuss ethical dilemmas in anesthesia. What are dilemmas? See, whenever there is a question of what is right and what is wrong, that is ethics. Ethics is a concerned with what is morally good and bad and what is morally right or wrong. So there are four basic principles of ethics. First is the principle of autonomy. Second is principle of non-malfeasance. Third is principle of beneficence. And last but not least is the principle of justice. These are the four basic principles of ethics. So what is ethical dilemma? Ethical dilemma means to do or not to do. That is the question you ask yourself. And whenever such question arises, that is a dilemma. Choosing between the dinner you promised to your family and a call for emergency LSCS. So it is a situation like dilemma, that what to choose, whether it is your family or your patients. So this is the song which clearly give you the idea what is dilemma. One more song which gives you the idea what is dilemma. So these are the situations where there is a dilemma. Maar diya jaye ya chhod diya jaye. So an ethical dilemma is a conflict between ethical principle will be compromised. So you have to select that what to do. Analyzing the option and their consequences provides the basic element of decision making. If we go to the first principle of ethics, the first principle is principle of autonomy. Autonomy is a Latin word that is known as self-rule. So we have an obligation to respect the autonomy of the patient. And that's why the role of consent comes. This is called a principle of human dignity. That means we have to respect the decision of the patient, and we are not supposed to force the decision from our side on the patient. So that is the basic thing of counseling and consent. So what is the role of an anesthetist? See, we all know that anesthesia is a separate procedure, and according to, as it is a separate procedure, anesthetist should take separate consent for anesthesia. And while taking consent, it is always advisable to inform the patient, to give on or pass on the adequate information to the patient. And what is the meaning of adequate information? You have to inform the patient that what is the purpose of treatment, what kind of procedure you are going to do with the patient, what are the benefits, what are the alternatives available, what are the side effects of anesthesia. And after informing or after giving the adequate information to the patient, then let us leave on the patient to take decision that what kind of anesthesia patient wants to undergo. Can patient in severe pain give consent? That is the dilemma. Suppose patient is in labor, in severe pain, or suppose patient is on table in severe pain. Can the consent of patient will be okay as per law? The answer is the consent should be a free consent, means without any coercion, without any undue influence. Now, pain, when patient is in severe pain, then patient cannot give consent. As per one of the decisions given by Supreme Court, when patient was on table under spinal anesthesia, consent was taken. Now, that consent, although patient was conscious above the level of spine, but still, as patient was on table, that consent was not considered as a valid consent because the patient was not in the position to give free consent. So that's why the consent taken on table, even if patient is conscious under spinal anesthesia, that is not a valid consent. What is the principle of non-malfeasance? Non-malfeasance means we should do no harm to the patient. Now, what are the situations? So, pre-op anesthetic checkup to be done always, because we are not supposed to do harm to the patient. And we all know that anesthetist leaving hospital before shifting, sometimes even before closure. These are the problems, because anesthetists are usually fast moving creatures and they enter the hospital very late and they leave the hospital very quickly after completing the operation. This habit needs to be changed as per principle of ethics, because pre-op anesthetic assessment is must, and it should not be done on table. It should be done at least outside operation theater. So before giving anesthesia, it should be made a habit by the anesthetist that anesthetist should meet the patient, should explain the patient the alternatives, the benefits, side effects of anesthesia, and take the separate anesthetic consent. The consent should be signed by the patient as well as by the anesthetist, and one witness from the side of doctor and one witness from the side of patient. Now, it is the practice. We have seen in our practice that many of the anesthetists are taking calls very frequently, and even before closure, they try to leave the hospital to attend another patient at another hospital. This habit needs to be changed. Actually, after completion of operation, anesthetist should be with the patient till patient is shifted from the operation theater. So that habit is to be changed. Giving anesthesia even without looking that pre-op investigations are done or not. Many cases we have come across in which the anesthetist comes at the end when patient, and without going into detail that which investigations are performed or not performed, they give directly the anesthesia. So these are a few things which needs care to be taken. Now, giving anesthesia in a patient who is not nil by mouth. Sometimes we have come across in our practice that there are a few patients coming for MTP. That MTP is a very minor procedure. So that patient may not be nil by mouth, but as doctor is in hurry, patient is in hurry, we used to give anti-emetic injections and we give anesthesia even when patient is not nil by mouth. So this habit also needs to be changed. So because we should do no harm to the patient. Giving anesthesia in a patient in whom surgery is not indicated. Now again there is a dilemma. Suppose you know that the surgery is not indicated in a particular patient, but as you are called by the doctor, and if you refuse giving anesthesia, you will spoil the relations with the surgeon. So you cannot refuse in that situation. So this is a situation of dilemma, whether to be helpful in a surgery which is not indicated, attending and inducing more than one patient at a time. We have seen that simultaneously two tables are attended by a single anesthetist, and this should never be entertained. Giving anesthesia without proper facilities. Again, this is going to cause harm to the patient, and we should not do any harm to the patient. So before giving anesthesia, anesthetist should check that whether oxygen is available in the hospital or not, whether trolley or monitor available or not, whether emergency medicines are available or not. We have come across in our practice many cases where anesthetist has given anesthesia without checking that whether oxygen is available or not. And once something happens, and then when they open the cylinder, they find that oxygen cylinder is empty and there is no oxygen available. Later on, they develop the conflict, okay, in between surgeon and anesthetist. The anesthetist claimed that there was no oxygen and that's why the complication occurred. And surgeon says that it was a duty of anesthetist to first confirm before giving anesthesia whether oxygen is available or not. So these are the all problems which we face. And whenever there is any conflict between surgeon and anesthetist, the beneficiary is the patient and the relatives while going to the suit in the court. Third principle is principle of beneficence. So basic thing is that we should not do any harm, but we should do whatever is in the benefit of the patient. Now suppose there is a patient of severe preeclampsia. Now as an anesthetist, it is indicated that GA should be preferred. But patient now forcing you that I do not want to take GA, I want to take spinal only. So if it is not indicated, then you should not entertain the demand of the patient. So you should do whatever is in the benefit of the patient. So whenever there are conflicting requirements, higher emphasis should be given to goodness at the expense of evil. In health, especially in anesthesiology, beneficence is acting in behalf of patient and their health, promoting health and preventing anesthetic complications. Whether to administer blood to the patient at the surgeon's request, when the anesthesiologist strongly believe that transfusion is not necessary. Now again, these are the dilemma, situations of dilemma which used to happen in day-to-day practice. So sometimes surgeon demands that you should start immediately the blood, but anesthetist do not want to start blood and he doesn't see any indication. So what should be done in such dilemma situation? So whatever decision you should take the decision in the benefit of the patient. Whether to use a cheaper but less effective medicines because the hospital is pressurizing the anesthesiological department to cut cost. So whether it should be entertained or not. These are all the situations of dilemma in day-to-day practice. Whether to take or seek informed consent from a patient who has received a small dose of midazolam. So that means patient is in sedation. So whether you should take consent from the patient or not, ideally it should not be taken from the patient. Whether to specifically inform an anxious patient about the risk of death from anesthesia. See the decision of Samira Kohli versus Dr. Prabha Manchanda. It is said that the common uniform risks are to be explained to the patient. The risks are not supposed to be explained in such a way that patient will never become ready to take anesthesia under the risk of death. So if you will tell patient that 1 out of 1,000 patient dies on table when anesthesia is given, no patient will become ready. So basically, there is a need to develop common uniform consent by different different association. And anesthetist association should also come out with common uniform consent, which should be made applicable all over India. Then it will be acceptable by court of law. Now, whenever there is a conflict that two patients are there at one time in the hospital, so emergency patient is to be looked after first. So the patient who is at higher risk should be looked after first. This is the principle of justice. So whatever is justifiable, that should be done by the doctor. Many more issues to be touched. when to inform regarding complication to the patients. So if some complication occur in the operation theater, when to inform, whether it should be informed immediately, whether you should try to settle the patient first and then later on inform the relatives. So these are the situations of dilemma which have no answers. Do not resuscitate, again is a there is no answer. If we go through the decision of Supreme Court, there is nothing like do not resuscitation. If you want to remove the resuscitation or remove the ventilator care of the patient, then you have to take permission from the court. Only then you can remove the ventilator. Whether to intubate in emergency, you have to intubate if it is an emergency to save the life of the patient. And whenever something is necessary to save the life of the patient, no consent at all is required. Now, whether post-mortem in case of death is to be advised or not. See, whenever there is a death on table in 4-wall, it is always advisable that you should ask for PM. Even if you are sure regarding the cause of death, even then, we always recommend that you should advise that you should write in the case paper that cause of death cannot be given by 100% certainty, and that's why police is to be informed and post-mortem is recommended, and you have to inform police. So whenever there is a death on table, it is advisable to advise post-mortem and hand over the body to the police. Now, suppose the relatives are creating problems, even then you may hand over the body to the relatives to avoid the mob violence at your hospital. But once you inform police, your duty is over. So dear friends, in our practice, there is always dilemmas in between ethics and morals. There are always dilemmas in between medical treatment and what is the legal problems or medical legal problems in future. So we have to practice by keeping balance in between our ethics and moral, in between our medical practice, taking into care the legal aspect of the practice. So thank you very much, dear friends.
Thank you very much, sir. Basically, question answer after this third lecture. So number of question is there. Now I invite Dr. Dilip Ranparia to invite our third speaker, IV paracetamol from Alchem Laboratory. Dr. Dilip is the president of Surat City branch, Gujarat State branch. Dr. Dilip. Yes.
Hello.
Dr. Yes. For introduction of Dr.
So, good evening, everybody. Our today's third topic is role of paracetamol in pain management, and speaker for that topic is Dr. Hemant Kanase. At present, he is working as medical advisor at Alchem Laboratory, Mumbai, and in the past, he served as assistant professor at KEM Hospital, and he also served as a medical officer at BYL Nair Hospital, Mumbai. Welcome, Dr. Hemant Kanase. Over to you.
Thank you, Dr. Dilip, for the warm welcome. First of all, I would like to congratulate Indian Society of Anesthesiology, the Gujarat State branch, for giving us an opportunity for having this scientific session with you and excellent sessions by Dr. Rakesh, Dr. Jitendra. With this, I also extend my warm regards to the President, Swati, Secretary Bradesh Bhai, and the moderators for this session, Atul and Dr. Preeti. So thank you. And with this, I start my session on pain management, which I feel is important for the anesthesiologist community. and role of a molecule which we are using from age wise. But let's look why it has achieved this position. So I would like to start my presentation with the definition, why pain management is important, pharmacotherapy in brief, role of IV paracetamol to be precise, what are the advantages of its pharmacokinetics, dynamics, and ending with some clinical evidence of IV paracetamol in pain management and advantages of the flexi bag, which Alchem has brought to the table. So we all know pain is a deleterious feeling, and it is now identified as a fifth vital sign, which is not only a problem for the patient, but sometimes problem to all the doctor community also for managing it. As we know from history, this word has come from Latin, which means punishment or penalty. Previously, this was a definition, but recently the ISP has proposed a new definition, which means it's an aversive sensory emotional experience which is caused by or resembles that is caused by actual or potential tissue injury. So there is an emotional component also to this process of pain management. Why pain management? As we all know, should know that this pain accompanies a physiological change, maybe in the form of increased heart rate, blood pressure, etc., which might cause problems in the primary cause of concern why the patient come. It might also lead to anxiety, depression, or aggression in the patient, which might hamper his overall patient care. So the pain should be managed. The objectives of minimizing the severity of the pain, which will facilitate the rapid recovery, improve the quality of life, reduce morbidity, and allow early discharge from the pain. Now, to take an example of post-operative pain, which all our anesthesiologist society is dealing with day in and day out, it is found that
Samraj? Hello?
is it audible now?
Yes, sir. Yes. Audible, but your slide is not. You can share again. Hello, Dr. Hemant?
Yes,
Yes.
yes.
I feel there's some network issue. I'll just connect with Dr. Hemant.
Dr. Hemant? Dr. Hemant? So some network problem is there. Dr. Rasesh bhai, you are there? Dr. Rasesh bhai? So,
Hello.
ha, Rasesh bhai.
This is Dr. Hemant, Atul bhai.
Yes.
Am I audible now?
Yes, yes, yes. Dr. Hemant, yes, you're audible.
Very sorry for the technical thing. Is the slide visible now?
No, 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 not.
It's coming.
Slide.
It's
coming. Sharing, yes.
Yeah, it is visible now.
Yes.
Okay, so continuing with the same thing that the post-operative pain, which is seen by the anesthesiologist day in and day out, is not completely managed, and more than 80% of our patients still experience the post-operative pain, which was there in year 95 as compared to year 2003 also. So definitely there is a need of pain management. If you see, the incidence of significant pain is still more than 50% both in MICU as well as SICU. And if you see these numbers, they are from the different studies which quote that more than 80% patients have the bad memories of pain even after the surgery has been conducted. So there is some remnant of this pain which might convert into chronic pain also. That's why there is need for an adequate pain management, and for that an appropriate assessment of pain is to be done. And IASP states that now how to assess the pain, that is being stated that even if the patient is unable to communicate is verbally, that doesn't mean that the patient is not suffering or the intensity of the pain is low. We should believe what the patient is saying, and that should be the dictum in pain management. And how it should be done, the pain assessment should include the location characteristics, severity, onset of pain, progression, duration, quality, where the pain is radiating, how is it elevating, or what are the exacerbating factors. And we should even calculate or remember what all previous therapies were given. So this will include a complete package when we are assessing the pain, and we all know there are different scales available for assessing the pain. Now, should we believe on the relatives or the surrogates for who tell us about the pain of the patient? Now, studies suggest that there was a support study which suggests that there is an overestimation of the pain when the surrogate or patient relatives talk about the patient for the pain. So it is better to believe on the patient than on the relatives. Now, moving on to the therapy part, there are different modalities of the pain. Telling the brief headings only: patient control analgesia, where the patient is the driving factor, and nurse control analgesia, regional blocks, and I would like to focus on the multimodal analgesia, which is a combination of different medication, which we'll look into the next slides, and the regional anesthetic technique. So depending on the type of pain, once we have assessed it, most probably it's a multimodal anesthesia which is used nowadays. So the commonly used pharmacological methods are paracetamol, NSAIDs, opioids, tramadol, adjuvants, and regional anesthesia. So these are the various drugs available in the basket of analgesics, which different permutations and combinations can be used depending upon the type of pain in the form of multimodal anesthesia. Now, if we look at the site of action, they act at various stages of the pain pathway, where NSAIDs and local anesthetic act at the initial, where at the perception side we have the general anesthetics and the opioids. So this was an observational study done in a center which is published in 2020, which says that in intraoperative and postoperative, mostly NSAIDs and paracetamol along with injection fentanyl was the combination which is used, and paracetamol could find almost 20% and 34% usage in both intraoperative and postoperative pain. So this analgesic ladder given by WHO mainly for cancer pain management, but we this is like an base for using the different types of drug in combinations. We all know that the base starts from non-opioids plus adjuvant, followed by addition of opioids according to their severity of pain. But the newer definition gives it a bidirectional approach, and there is a step 4 also, where invasive or and minimally invasive treatments are to be added in the form of regional nerve blocks. So we saw different modalities of what options we can permit and combine, but do we really have an ideal analgesic which will provide us a balance between the efficacy and the safety? Because we all know in this today's world now we are moving on towards a more of non-narcotic analgesics, maybe NSAIDs, which come with the disadvantage of side effects pertaining to GI tract, or maybe not possible to use in all comorbidities and are prone for drug interactions. So in this situation, if we take example of diclofenac, they are prone for this deleterious effect on platelets, increased GI ulcers. Or if we take example of opioids, now these are few which are mentioned, but there are many apart from respiratory depression and nausea. So there is a need of the hour to look back for an analgesic which has shown a comparable efficacy And on the safety front, definitely it's way better than the NSAIDs and opioids. So one name we should remember, and that the safer option is paracetamol, because not associated with any deleterious hematological or renal effects, not associated with any side effect as such, and is safe in comorbidities, and hence recommended by various foundations like National Kidney, which is stating it as a narcotic or analgesic of choice. And definitely it has few drug interactions and no absolute contraindications. So paracetamol, as we know, is a non-opioid analgesic, first step analgesic for mild to moderate pain. Apart from the analgesic effect, it is also having an antipyretic effect. And mechanism, it acts by blocking the central prostaglandin synthesis by inhibiting the COX enzyme. Now this is has an COX-3 inhibition also, which is acting centrally. Now one thing to remember, it for mild to moderate pain, it's definitely a very good drug. But when we increase the severity of pain, definitely paracetamol should be added by other agents like NSAIDs or opioids. Now, why IV paracetamol and why not oral? The answer lies in its pharmacokinetics, that the way how the drug is acting in the body, because the pharmacokinetic doesn't change much in different types of surgeries or different types of therapy.
Hello,
Hello?
hello, Dr.
Yeah.
Hemant.
Yes, ma'am. Hello?
I think there is some problem.
Am I audible?
Yes, sir, you're audible.
Yes.
Yes, you are audible very well.
Okay, so in paracetamol, the answer lies in the IV paracetamol, the pharmacokinetics. The
There is
pharmacokinetics.
some problem with network.
Prithiban, it is, I think it is on your side, not the general
Yes.
problem.
Is
Yes, ma'am.
it clear?
Okay, go ahead.
Okay, thank you. So there is no variability to patient when it comes to pharmacokinetics. The Cmax, the maximum concentration, is achieved within 15 minutes. That time we can expect the maximum analgesic effect, that is 15 to 30 minutes. And the plasma half-life is 2.7 hours. Now, if we go to the metabolism, we all know that it is metabolized in the liver by a major pathway, that is glucuronidation, and a minor pathway, that is CYP450. But when we give an excessive dose, there might be accumulation of the toxic metabolite, that is NAPQI, and which is normally excreted by conjugation with glutathione. But in a hepatic compromised patient, this glutathione reserves might be down, and hence that might be toxic to the liver, or else the metabolite are excreted in kidney. So moving on to the pharmacodynamics, mainly the pain relief which is achieved, it can be starting at 15 minutes, as we say, and the maximum effect is seen in 1 hour. Main thing to remember here is the peak plasma concentration influences the analgesic effect and not the average plasma concentration, which we should remember. Now moving on to some clinical evidences. Now this is from a Cochrane review of 75 studies, which included 7,200 patients, which said that a good quality evidence of a single dose paracetamol is seen in almost 36% patients, which were in their study. And this is another study which shows an opioid sparing effect of paracetamol when used in an orthopedic study. Now, this is a study from a surgical ICU where patients had head and neck cancer surgery, and they showed that there is an early discharge when the patient were used paracetamol. Now, when comparing efficacy of paracetamol with fentanyl in mild to moderate pain, the VAS score was almost similar. There was non-significant difference, and the adverse effects seen in both the arms were comparable to paracetamol as well as fentanyl. Now, this is a mild to moderate pain. Moving on to dosage, everybody must be knowing the dosage 10 to 15 milligram, but I would like to highlight that up to 50 kg of the patient, we should be no problem delivering a dose up to 4 grams. But once the patient is below 50 kg, please go by the dosing chart of 15 milligram per kg. Only condition when the patient is hepatically impaired, please reduce the dose by 3 kg. In case of renal impairment, the dosing interval should be increased to 6 hourly, or else the normal dosing interval is 4 hours. And the dosage administration should be done over a 15-minute infusion. Now that was for the paracetamol till now, but Alchem has brought a Flexibac formulation in 1%. It is the same molecule, same composition, same pharmacological class, and same indication. So what is different? For that, we should look at the problem first. What is there? Basically, in the packaging, we all know we have the PVC packages mostly, which contain these plasticizers, which are added to increase the flexibility. And main plasticizer is diethyl hexyl thiolate, which is usually a softener, and this might react with the ingredients and leach out the chloric acid, and it is toxic to the nature also and to human health also. There are different papers highlighting the toxic effects of this DEHP to the extent of hypothesis of even generating cancer. So these are few advantages of the flexi bag over glass also, that glass might break and storage problem is there. Plastic bottle, yes, it is there, but it has only one port. It is open infusion system, while flexi bag offers a closed infusion system. It is self-collapsible, flexible, non-PVC, non-DHP. It is environmental friendly. What advantage it offers, that it is easy to handle, easy to store, is environmental friendly and closed infusion system, which offers an aseptic conditions, especially to our critically ill patients. So to summarize my session, I would say that choosing appropriate analgesic is important. We all know NSAIDs and opioid are really efficacious when it comes to moderate to severe. That's why we should remember that in the mild to moderate case, there is an option, a safer option of paracetamol. And clinical studies have demonstrated its opioid sparing effects. Plus now the Alchem has brought a non-PVC DHP free packing with closed infusion system, which will give advantage and more value to this paracetamol. So with this, I end my session. Thank you.
Thank you very much. Such a nice presentation. I invite Dr. Rasesh Diwan, our ISACON chairman, or say a few words about a conference in 2021. Dr. Rasesh bhai.
Thank you, Atul. Our Honorable National Secretary, Dr. Naveen, Swatiben, President GSB, Badresh, Secretary, President-elect Dr. Pritiben, and Atul. Thank you so much for giving me a platform. There is nothing much to say, honestly speaking, but I want to make an appeal to everyone that please keep the spirit on. We shall overcome. We'll fight over the corona, and I'm very hopeful that next November we have a regular formal conference at the same venue of Mahatma Mandir, and we all will participate very actively. We are very hopeful to be there like that. I wish and I request Dr. Badresh and Dr. Swati Bhatt, please make some of very important international CMEs now, so that the ISACON remains in the visibility of people, not only in Gujarat, but across the country. And we'll try to do more and more such events in the next 6 months of time. I take an appeal given by Dr. Naveen Malhotra that we should be going back to the quiz questions on the application. I'm sure with Dr. Sunil, we'll try to reorganize that. And I need everybody's support from all the stalwarts and academicians in our Gujarat to participate, contribute to the questions, and we make a very wonderful visibility to everyone across the country. I'm very sure we'll have a wonderful ISACON next November. I'm very hopeful. Thank you so much. And this was a very good CME, and everybody has done a wonderful job. There were very good lectures. And special thanks to Dr. Rakesh and all the other two speakers. They've given a wonderful guidelines to us. Thank you so much.
Thank you, Rasesh Bhai, sir. Now we are going for the question answer. Dr. Preeti, can you start? Preeti? Okay.
Hello. Now I must thank all the speakers for their excellent presentations and clearing our dilemma in clinical practice. Thank you all for attending this webinar. I have gathered some questions, and the first question is for Dr. Rakesh Garg.
Yes, ma'am.
Am I audible?
Yes, ma'am, you're audible.
Yes. The first question is the patient is asymptomatic, RT-PCR is negative, and on HRCT, CORAD's grade 5. So, what is your strategy for elective surgery?
The CT scan is showing something.
CT scan is showing CORAD's grade 5.
Okay, right. So the point here is we said that the respiratory involvement in COVID-19, they will bring about some CT changes. So at present, CT-based evaluation for the infectivity is not being done. It just shows that there is some change in the respiratory system, which I highlighted that in case if somebody has respiratory involvement during the disease process itself, the preoperative period, the respiratory status needs to be evaluated as we do for patients with coronary pulmonary disease. So in case if they come into the category that the cardiac function, the respiratory functions are normal, we can take up, or else we can try to optimize them in due course of time. But usually these patients should be awaited for around 3 to 4 weeks so that some type of inflammatory response which is ongoing settles down and there is a recovery phase, so that by the induction of anesthesia and respiratory ventilatory interventions, you are not going to create more insult by barotrauma or volume trauma or by manipulation. So 4 weeks we can stay and then get the surgery done. But yes, an additional respiratory assessment from clinical point of view, or if required, we can do some pulmonary function test to take a decision for the surgical intervention.
Sir,
then the next question is, what is your opinion on bedside USG lung scan in COVID patient for treatment improvement?
Right. I think this is a very, very good question. And when we are talking of point of care ultrasound, nowadays focus on all point of time. And I've seen a couple of papers, not couple, I think one paper which has been published where they have found the utility of the lung involvement with COVID-19. So I think though we do not have robust data, but what those ultrasonic findings, they have mentioned that whether there are presence of B lines and there are chances of some consolidation and something like this, which can be picked up. Even the resolution can be picked up on ultrasound. It can be used, those who are expert, though we do not have very focused paper for its outcome. But yes, for assessment tool, it can be used. I think there is no confusion as we are using chest X-ray screening. But I think those who are experts can pick up ultrasonographic finding for lung scan. They should go and they can be done to look for the early changes.
Yes, Preeti, just one more question. Dr. Rakesh, a case posted for CA lung for right lower lobectomy post-COVID 25 days. Recent RT-PCR negative, but persistent ground glass opacity in both the lung. That is semi-emergency. Can he operate or not?
I think another very, very important question. These are very clinically relevant questions. I must appreciate the relevance of these questions. Now, when I said when somebody becomes COVID positive, he has respiratory involvement, lung involvement. The lung involvement initially there will be some consolidation, there may be some thrombosis, and that will subsequently lead to resolution, or if it is a major insult, it can be into the form of fibrosis. So if you get a CT scan done, they will show some changes. So once the patient is non-infective, the RT-PCR is negative. If you do antibody titers, it is showing positive. So this means the infectivity has gone down. Now this patient is posted for surgery, say for example, non-cancer surgery, then based on lung function test, we can go about it. But since it is a lung surgery, then we have to take a decision on a semi-emergency basis, on an urgent basis, and we should go ahead and do it. But remember, since we are directly including the lungs, all personal protective equipments should be taken care of when these patients are being managed. So that is the crux. We cannot postpone the surgery for another couple of weeks, but we can go ahead and do it. And obviously, the baseline assessment and prognostication needs to be done as we do for other lung function tests for any thoracic surgery. So that can be done for these patients also.
One last question, sir. What is the role of inhalation steroids in reducing COVID respiratory damage?
I think we don't have any data with regards to the use of inhalation steroids. Probably the reason would be that it is a systemic inflammatory response and some amount of the thrombotic phenomena, but more of a systemic response it is. So there is no evidence as of now that the use of inhaled steroids, as you do for other chronic pulmonary disease, has any role in COVID-19. As of now, the definite role is only with intravenous or maybe the oral steroids, and dexamethasone or maybe methylprednisolone can be used. Most of the studies are coming with dexamethasone, but equivalent methylprednisolone can be used for these patients as well. So no role of inhaled steroids for the purpose of COVID-19 respiratory dysfunction.
The dosing of paracetamol in hepatic and renally compromised patient.
Okay, sir. As I said in my seminar, mostly the metabolites of paracetamol are excreted in urine. So in renally compromised patient, there is no change in the dosing as such, but the dosing interval should be increased, which is normally 4 hourly. Now we have to increase it to 6 hours. Now, and that too, if I'm talking about the renally compromised, we have to consider only when the creatinine clearance goes down below 30. That time we have to think about that. In hepatic compromise, there is no dosing interval difference. We have to reduce the dose. Daily dose should be reduced to 3 grams. So that is the precaution to be taken in case of hepatic and renally compromised patients.
Okay, thank you. Dr. Rakesh, sir, that's a very routinely asymptomatic RT-PCR positive patients. When earliest we can go for the plant surgery, specifically plant surgery?
4 weeks, sir. I think I will suggest, because if you see I showed you one graph wherein the chances of IgM and then IgG rising and infectivity, this is one aspect. Second is it will be not a normalization but optimization of the physiological status. So I think most of the studies and most of the parameters, even at our place, we wait for 4 weeks after the COVID infection to schedule them for elective surgery. So that should be the best ideal time for doing it. We do not have a robust evidence, but it appears to be the acceptable time frame.
Sir, I have one question. Sir, are there any specific investigation or any routine advice for a pregnant patient who is positive, COVID positive, and posted for say elective CS or emergency CS? Because this such type of patients are coming routinely to our tertiary hospitals.
So now the two things. One is, you said elective LSCS, and one is an emergency or urgent LSCS. So if it is an emergent or urgent LSCS, I think there is no need to wait for any testing to be done. But obviously you can send the sample and get the case done with all PPE precautions that needs to be taken care of. And subsequently, whenever the test report comes, the subsequent management of patient and the newborn can be taken accordingly. But if it is an elective LSCS and it is planned for some other obstetric reason and you have the time, then obviously you can send an RT-PCR or a CBNet TrueNet before the surgical intervention. RT-PCR usually take at most of the places around, say, half a day to 1 day usually. CBNet TrueNet is a cartridge base. Usually the test comes within 2 to 4 hours. So depending upon the urgency, that at what time they want to post the LSCS, these tests can be done and the subsequent management can be done accordingly. Only the aspect would be that the post LSCS, depending upon the test report that you have received, is the mother and the baby should be counseled. There are some precautions that we have to give to the mother, that they can wear a mask. She should be careful for the hand hygiene while breastfeeding. So those precautions must be given to the mother whenever the test report come positive, or If the patient is symptomatic, then only again these all precautions needs to be followed during the breastfeeding. For anesthesiologist and the other person in the perioperative care should follow all the PPE precautions while getting the case done.
Thank you, sir.
Okay.
So just one more question.
Please, madam.
Sir, do you recommend invasive monitoring in COVID positive posted for elective surgery, say major surgery, thoracoabdominal surgery?
So as I mentioned in my session, that the use of extra investigations or extra monitoring tool in the perioperative care will be decided by the patient's physiological status or functional capacity. So COVID-19 infection, history of COVID-19 infection per se is not an indicator of some extra test or extra monitoring tool. But for example, say a patient comes to you, he is posted for some surgical intervention and he says that he gets dyspnea on 2 flights of stairs. It could be because of cardiac reason or respiratory reasons. Now this becomes an indication to assess further these patients, and accordingly you can use some of the invasive monitoring if there is a clinical indication based on your assessment. So that is how you can decide it, as we do for other cardiac regions, like for example,
Okay.
CCADs or the advanced diabetic or end-stage renal disease. Same principle will be applicable here. The presence of the history of COVID-19 is not an indication for routine use of invasive monitoring for elective surgical interventions.
Any further question?
Sir, Dr. Jitendra Sharma sir is there online. Jitendra Sharma sir.
No, ma'am, he is not here.
Okay.
One last question,
Okay,
Dr.
madam.
Rakesh. One last question. I think it is not a proper question for you, but someone has raised the question. For elective major open heart surgery, what is the protocol at your institution in this COVID era?
I think I will refrain from this question because I'm not doing cardiac
Yeah,
anesthesia. So
exactly.
I show my
Okay.
inability to answer this one.
Okay. Okay.
Okay. Now,
So thank you, sir.
Thank you very much, sir. Just for
Yes. Yes, sir. Go ahead.
Mr. Arvindan Chakraborty, he's from Alchem Laboratory Pharmaceutical. He's a sales head. For few words, please.
Yeah, good evening, doctors. Good evening, all the eminent delegates. And thanks for joining in this COVID and crisis situation. It's a real honor, sir and respected madam, to be in this platform. And really, we are going through a very tough situation. And in this, we always require everybody, but more than everybody, doctors are the most important. And we are very much blessed that we got all of you tonight in this platform. And it's a vote of thanks from Alchem Hospicare. And I'm based out of Bombay in head office. So I heartfully thanks from my side to all of you, and thanks for being a part of this program. We and our team will definitely come personally and visit you and pay our regards also. Thank you. Thanks a lot. Good night. Good night.
We hope so. Our national conference is Ahmedabad. So please join us in too much with wholehearted.
Definitely, sir. Definitely. I will also personally come and meet.
Okay. Thank you very much.
Thank you. Thank you.
Last, specifically myself and Dr. Preeti, we are fortunate that our thanks and thank you very much to our President, Dr. Swati Bhatt, and Secretary, Dr. Badresh Shah, without whose motivation this webinar would not have been materialized. She and Badresh boosted our spirit always. So now concluding the session, Secretary, Dr. Badresh Shah, give word of thanks. Yes, sir.
Thank you, Atul. Thank you, Atul. Before giving vote of thanks, first I want to congratulate all GSB members for adding 14th branch in this year. This year in last 2 years we added 4 branches. So our growth is 40%. Our national secretary, Dr. Naveen sir, is very dynamic and very capable person. So he is always putting high targets, giving a high target. So we will definitely try to achieve or to reach near to that target. But once again, congratulations for 40% growth in last 2 years.
I will take that.
Now, on behalf of ISA Gujarat State Branch, Special thanks to our National Secretary, Dr. Naveen sir, for his esteemed presence and encouraging words. My heartily thanks to all three speakers, Dr. Rakesh Garg sir, Dr. Gitendra ji, and Dr. Hemant ji, for delivering very interesting and knowledgeable speech on current topics. Thanks to Mr. Narendra, Mr. Rahul, Mr. Suraj, and Mr. Harinandan from Alchem Labs, and to all state and city branch post holder for supporting this GSB event. And special thanks to Dr. Pritiben, Dr. Atul, Dr. Mangal, and Dr. Dilip. Thanks to Dr. Rasesh Bhai for constantly guiding us. Last but not least, without delegates, success of any event is impossible. So thanks to all those who attended this. Thank you, friends.
Coach. Sir, just one AV we wanted to launch, in presence of all the eminent personalities, we wanted to launch Hospimol Flexi Bag.
Yes, sir. I will give it. That's but to finish up Dr. Badre's speech.
Okay, sir.
I finished my speech. Atul, thank you.
Okay. So, Alchem Pharma just show some video for 2 to 3 minutes. Please share the video.
Greetings from Alchem Laboratories. Doctor, as you know that Alchem is the 5th largest pharmaceutical company in India and present in all major therapy areas. Globally, Alchem is present in 56 countries and having strong presence in US market with more than 125 ANDAs. Doctor, Alchem Laboratories has 14 brands in the top 300 brands with a strong presence in pain management. In this segment, Alchem has brands like Sumo, Enzoflam, Hospimol, Gemcal, Uprise D3 and many more. Doctor, Alchem Hospicare is the highest growing company in critical care in financial year 2020. It is perceived as the true ICU care division of Alchem. Hospicare is dedicated towards serving critical care and it stands notable among the fraternity for need of quality medicines. Doctor, pain management is an integral part of the treatment in hospital care. Paracetamol is the most preferred molecule for primary pain and fever management due to the safety profile. Available paracetamol containers are conventional and difficult to handle. Hence, need of the hour is novel approach. Paracetamol is the most widely used molecule in hospital service since 1880s. IV paracetamol reaches a significantly higher 70% maximum concentration within 15 minutes of infusion and so is one of the most favorable NSAID. A study in moderate number of patients shows that paracetamol reduces the requirement of opioids, a decrease by 14.9%. IV paracetamol has broad compatibility with other analgesics. IV paracetamol improves pain relief, expedites mobilization and rehabilitation, and reduces healthcare costs. Introducing a novel drug delivery system. Hospimol FlexiBag ensures quality with flexibility. Doctor, Hospimol FlexiBag offers closed infusion system to maintain aseptic conditions. Hospimol FlexiBag has 2 ports, hence no external venting is required. Doctor, Hospimol FlexiBag is a self-collapsible or flexible non-PVC bag which provides greater durability. Hospimol FlexiBag is also environment friendly. Unlike other PVC bags, it does not release toxins of HCl and is DEHP free. Doctor, Hospimol FlexiBag is easier to dispose as compared to other containers. Hospimol FlexiBag has reduced weight and there are no chances of breakage. Doctor, Hospimol FlexiBag provides triple E benefit: ease of handling, ease of storage, and ease on environment. Doctor, Please prescribe Hospimol Flexibag to your next patient to ensure quality with flexibility. Doctor, Hospimol Flexibag is available in your hospital pharmacy.
So we conclude the session, and I'm thankful to our local Alchem representative, Dr. Mr. Narendra Bhai, Mr. Rahul Bhai, and Suraj from the Bombay and IT team. Thank you, everybody. Thank you very much. So we close this. Any, madam, we close the program.
Yes, Atul Bhai.
Thank you very much.
Thank you.
Thank you all.
Thank you all,
Thank you.
speakers,
Thank
office bearers, everybody.
Yeah.
So we leave the meeting.
We will have another academic session in your near future.
Yes, madam, definitely.
As Malhotra sir has advised us to have more academic session, with this team we are hopeful to have more such sessions.
Madam, we discussed our GBM meeting, and we are planning for the state conference online.
Yes.
So we can discuss in the meeting.
We will have one more meeting of GBM.
Yes, agree.
Because at that time dates were not fixed up.
Yes. But this will take arrange the meeting.
We'll see.
Okay.
We had many options, and then we will decide.
Agree.
Yes.
Agree, madam.
Yes, sir.